This is our personal plight to end racial disparities in PAD care, and we have Dr. Richard Browne and his mission to save legs and change lives. Dr. Browne is a renowned cardiologist and a senior medical executive for cardiovascular and metabolism Janssen. He will be sharing his personal connection with PAD and his efforts to drive change through Janssen's Save Legs, Change Lives campaign. In our keynote fireside chat, let's welcome Dr. Richard Browne. Dr. Browne, thank you for joining us today.
Thank you for having me. This is a extremely important topic.
Let's start with a basic question. Did you always want to be a doctor?
No, I actually, when I was in 10th grade, I was a very good piano player. So I played the keyboards, and me and three of my friends who were 11th graders, we started a band. I grew up in St. Croix in the U.S. Virgin Islands. Our band was called 17 Plus because I was 16, the other three band members were 17. And we would play music on the beach and sell food and make money. And then I got an opportunity when I was an 11th grader to be on the radio as a radio announcer at a popular radio station in St. Croix. And ultimately, what I wanted to do was I wanted to live that life for the rest of my life. I wanted to play music and be on the radio. And my mom wasn't having that. She said, absolutely not. That's not going to happen. So I was actually looking for an opportunity to delay going to college and being able to stay in the Virgin Islands longer. And Boston University had a very unique program where they allowed you to be accepted into Boston University and also Boston University School of Medicine, but you could start college at any accredited college in the U.S. or one of its territories. So I applied, got into that program, which allowed me to stay in the Virgin Islands a couple more years playing music and being on the radio. And so that is what drove me towards entering Boston University School of Medicine and becoming a physician. So it was my desire to play music and be on the radio. That's what got me into medicine.
Okay. What drew you to interventional cardiology?
So the reason that I became a cardiologist was I felt that cardiology was somewhat straightforward, meaning that people could have plumbing problems where you restore blood flow. They could have electrical problems where you speed up the heart. And cardiology is one of the most studied areas in medicine. There are so many clinical trials that tell us what is the right way to treat patients with validated evidence. And I also love the combination of being able to be with patients, take care of them, sit down in the office, get to know their family, get to know their family members, coupled with the ability to do procedures and do work with my hand. So cardiology became sort of a thing that made a lot of sense to me and my personality.
Okay. Um, ha- Before PAD affected your family, had you treated anyone with PAD?
Yeah, so I and it's interesting. I was looking at the statistics that Mary had on the screen. And, as someone who is well read in this area, I would say a third of the statistics Mary put up today, I didn't even know. So back in the day when I was in medical school and early parts of my career, I'll be honest, if little is known now, even littler was known a couple decades ago. So I had treated patients with peripheral artery disease for sure, but not really understanding that it was a disease state that not only increases your risk of having an amputation, but it also is a marker of increased risk of stroke, increased risk of heart attack, increased risk of cardiovascular death. All those things really did not become apparent to me until it affected me on a personal level.
Okay, thank you. Um, I've seen interviews with you, and hopefully it's not too personal, but could you explain what it was like watching your father-in-law go through it?
Yeah, so let me explain to folks the relationship I had with my father-in-law, Russell. Um, so I met his daughter, Lauren, um, um, right after I'd graduated from high school. So here was this young dude showing up. She lived on St. Thomas, and the first encounter we ever had was I was in his house, and I was very comfortable in his home, and my feet were up on his coffee stand, and he kind of
Hmm.
walked in, and he was like, "Who in the world is this young whippersnapper with his feet up on my table?" And he basically said, "Next time you come into my house, if I see your feet up on my table, you will never be back here again." So that was our literal first encounter, and and so he was that sort of very direct, big spirited person. And as I got to know him, one of his dreams was he really wanted to retire in St. Thomas. He sort of, when he was at the end of his career, he dreamed of sort of going to the beach and walking on the beach and enjoying his retirement days on an island. And while I was part of his life, he became a very, very big part of mine. And my wife has two sisters. She had no brothers, so I think he kind of took me on as the son that he never had, and I developed a very close relationship with him, his wife Susan, and my sisters-in-law. The things started to unravel, and I want to give dates so that people can understand the connection between my professional life and my personal life. I finished my cardiology fellowship in 2000, and I moved to Charlotte, North Carolina, which is where I still live. So remember that date, 2000, when I finished up my training.
Okay.
So in the late 1990s, um, um, Lauren's father, my father-in-law, Russell, he went to the doctor, and the doctor told him that his kidney function had deteriorated. He had actually been a diabetic for a long time, was being treated by physicians in the Virgin Islands. I actually had him go up to Boston to see a kidney specialist at Brigham and Women's Hospital, where I did some of my training. And for the first time ever, he was placed on a ACE inhibitor. For the first time ever, he was placed on a statin drug. So there was a significant delay in his care that Mary touched on, just the care of his diabetes. Then things started to unravel. He rapidly developed renal failure and ended up on dialysis, and still could receive dialysis in the Virgin Islands and continued to live there and continued to be okay. But then one day he developed significant shortness of breath and some chest discomfort, and he was having a heart attack. That resulted in him being emergently transferred from St. Thomas to Atlanta, Georgia. That was the day that he left St. Thomas, and he never ever went back. So this dream of retiring in St. Thomas never ever ever happened. He gets to Atlanta, underwent a heart catheterization, and had open heart surgery. And it's interesting now. In retrospect, I look back at his care. He had open heart surgery, but still, there was really no attempt to get him on aggressive medical therapy. Um, I still feel in my heart, without question, that the care that he received in Atlanta was not the care that the governor of Georgia would have received.
Right.
He subsequently had three really bad years. First of all, His left leg one day started feeling heavy whenever he would walk, and he went to see his physician. His physician told him that he had severe circulatory problems in his leg. He had an ulcer on his leg, and again, as Mary showed, where a high percentage of patients have no diagnostic testing or an angiogram before an amputation, he fell into that category. He was told, hey, the leg has to go, and it was amputated in 2001. About 12 months later, um, one of his arms turned black pretty acutely. He again went to the hospital and was told the treatment is an amputation. So one of his arms was then amputated. And then about 6 months later, he had an ulcer on his other leg, which again was never really addressed, and was told that his other leg needed to be amputated. So from a very short period of time, he had three limbs amputated. And that was a really tough time for the family. I mean, I want you to sort of close your eyes and think about somebody with no legs and one arm. You know, when I think about the rapid decline in his his um his life and his health and his manhood, it really it really, really affected me. Now, he died very soon after his last amputation. He died in 2003. And one of the things that happened in parallel to that was after he had his first amputation, we were at Crawford Long Hospital, my wife and I, and her mother and her sisters. And um, my wife said to me that, okay, my dad is having an amputation. Likely he'll never be able to walk properly again. So I'm going to become a runner. This was my wife telling me this in his honor. And you have to know my wife. She was not um, anything close to being a runner type person. Now, I didn't tell her that. And when she said it, I said, she's just upset. There's no way that's happening based on sort of her lifestyle and the way she was. But after that first amputation, she then signed up for a 3K race and trained for it and completed the 3K race. And then subsequently, she started running 5Ks and then she started running 10Ks. While she was taking on this becoming a runner journey, you know, her father died. He died in 2003. And then in 2007, our son, Ricky, was born. So Ricky was born 4 years after her dad died because of peripheral artery disease. And Lauren continued her journey of being this, you know, aggressive runner. So in 2013, so 10 years after her dad had died, she was now running marathons. And she said,
Wow.
this is the 10-year anniversary of my dad's death. I want to really do something to honor him. So she said, I'm going to run the Goofy Challenge. And what is the Goofy Challenge? It's something that happens in Disney World. The reason they call it the Goofy Challenge is you got to be crazy to do this. On Thursday you run a 5K. Then on Friday you run a 10K. Then on Saturday you run a half marathon, and then on Sunday you run a full marathon. So this time when she told me she was going to do that, I didn't say, well, I don't think so. I knew she could do it. So it was me, her, and Ricky. We went down there. I remember this weekend like it happened yesterday. We had a red Corolla that we had rented, and she ran her 5K, no problems. The Friday she ran her 10K, no problems. Then she's running a half marathon, and Ricky and I are kind of following her around in this red car, and she finishes it. She's doing great. We actually go to SeaWorld, and she's just become this sort of elite type of runner. And then on the Sunday, she had the full marathon to run. So she started it and was doing extremely well. And the race started and ended at Epcot Center in Disney. And so she's back in Epcot and she has about a mile and a half remaining to finish the marathon and finish the entire Goofy Challenge. And she came around a corner and I was holding Ricky in my right arm, and our eyes locked. And I saw her come around the corner. She looked at me. I looked at her. I was like, "Wow, this is so amazing that she's going to finish this race." She explained it to me. She said, um, all these years I've been running, and I've been running with this anger in my. I've just been running with this anger in my heart. And I turned around that corner and I look up and I see you holding my son. And I so desperately wish that he had met my father. And all of that was just too much. And
Wow.
that was the moment that it really, really hit me that the effect that peripheral artery disease and the peripheral artery disease related amputations had on my wife and her family.
Yeah, that's wow, that's powerful, Dr. Brown. We we know that you said that you believe that your father-in-law received suboptimal care. If he was if he was still here today and he walked into your office without you knowing him and knowing what you do know now, what advice would you give him and how would you explain PAD to him?
Yeah, so a couple of things. He never went to the doctor, diabetic, and had his shoes and socks removed during a visit. Um, you know, there was never an attempt to check his pulses and to see the degree of circulation in his legs. So the first thing I would tell him, which is what I would tell any patient who's at risk for peripheral artery disease, is take your shoes and your socks off when you go to the doctor. Force them to examine your feet because that is something that did not happen for him. The other thing that I would tell him is that we have a lot of great medications to modify risk factors, et cetera. But diet is so critical. He grew up in the Virgin Islands, which is a community where fried foods and sugary drinks and those types of things is very common. And quite frankly, um, it just I wish he knew more about proper diet and just eating healthy and the effect that that could have on his blood pressure and his cholesterol and his blood sugar levels, all that stuff. So that's something else that I would talk to him about. The other thing I would talk to him about is losing weight because he was overweight and never really emphasized that. We know that being overweight is a risk factor for peripheral artery disease, and that would be something else I would talk to him about. And then the final thing I'd talk to him about is advocating for himself. And again, this was the early 2000s, so it might be harder for him to advocate. And I have some guilt because we didn't advocate for him at that point. But again, what I knew was very limited. But I would say, hey, don't just accept, hey, the limb has got to go as the only option. Ask about options. Ask about, you know, are there things that could be potentially done to salvage and save my legs and my arm? And he did not advocate for himself. He just sort of took the recommendation of the physicians and did what they said.
Okay. Kim, jump in here.
Yes, we do have a question coming in from Sally. Sally, go ahead, ask your question of Dr. Browne.
Dr. Browne, my question is, I mean, you explained so beautifully everything. How would you explain to your son about his grandfather's situation, going through to inspire him to take steps to prevent it from happening to him? How would you actually explain that to your son?
Yeah, so I've actually one of the things that I do on a regular basis now is go into communities and talk to individuals in those communities about the risk factors associated with peripheral artery disease. As a matter of fact, right now I'm actually in San Francisco. I'm at the 100 Black Men of Oakland event, and after this I'm actually going to be speaking to folks about what are the risk factors, because there is such a lack of awareness about peripheral artery disease. And I've spoken to my son, I've explained to him that there's these things in your body called arteries, and sometimes you can develop plaque on the inner lining of those arteries, and that can obstruct blood flow to your brain and your heart and your legs. And so he has a good basic understanding of the pathophysiology of peripheral artery disease. But I also talked to him about things like high blood pressure and its relation to the amount of salt that you eat. And I cautioned him on that. I explained to him that his grandfather and also actually my father were diabetic, and talked to him about what diabetes is, and why he should, even though he's a teenager and all his friends are doing it, why he should be drinking non-sugary drinks and drinking things that are healthy. He has a good understanding of what cholesterol is. He's 16 years old. He's actually, had one time his cholesterol checked, and we went over the results, so he understands what high cholesterol is. And I've cautioned him because I know that as he grows up, he's going to have influence from friends to smoke and do other things, deep in the night. So I also made sure that he knows that not only does smoking increase your risk of cancer, primarily lung cancer, but it also is, it quadruples your chances of peripheral artery disease. And then I speak to him about being active, being physically active, and how important physical activity is in regards to cardiovascular and vascular health. So we've had conversations about the demise of his grandfather's health. And it's important that he recognizes as a young person that vascular disease is a decades type of process. It doesn't just happen overnight. So things that he is starting to do now as a teenager will affect his health when he's my age.
Thank you for that. Kim, on to you.
Yeah, and we do have a question coming in from Frank. Frank, what is your question for Dr. Browne?
Thanks, Kim. Hello, everyone from Chicago. Hello, Dr. Browne. You were actually featured on television in a very powerful documentary on ABC News Live. That's the streaming service for ABC. And one thing that really stood out to me is when you were honest about doctors making decisions under a so-called unconscious bias that causes them to make personal determinations. For example, that the patient would be better off after an amputation, really not considering how the patient feels about it. Now, how do we, as a community, convince these doctors that this mindset needs to change so we can save limbs? Thank you.
That's a great question. So let me just give you a personal non-PAD related example of unconscious bias. So one of my best friends is an orthopedic surgeon, very smart guy, excellent training, one of the top orthopedic doctors in Atlanta. He's Black, and he called me up one day because his watch told him that he might be in atrial fibrillation. Turns out that he was in atrial fibrillation, and he went to see a doctor for his atrial fibrillation. And because of his risk of stroke, it was recommended that he be placed on an anticoagulant, a blood thinner. And his doctor put him on a old 60-year-old type of treatment for atrial fibrillation when there were much, much better modern options that are more expensive. And quite frankly, he called me and I was shocked that, the newer medications had been out for almost a decade. The guidelines clearly documented that those were the treatment of choice for atrial fibrillation, but yet he was put on this really old form of medication. And I know exactly what happened. It was his doctor. He saw this Black man come into his office and he was like, oh, I've seen so many Black people come into this office that can't afford their medicine, that don't take their medicine after I prescribe it because they can't afford it. So I'm going to do him a favor and I'm going to put him on this suboptimal treatment because he'll be able to afford it. And quite frankly, he could have easily afforded, the standard of care. So that's an example of unconscious bias, right? The doctor wasn't trying to harm my friend, but because of all the biases and the lived experiences that he's had as a person or as a physician, he made a decision to give him something that was suboptimal. And the same thing is happening without question in the management of peripheral artery disease. I work at Johnson & Johnson now, and we've developed a tool called the heat map, where we look at Medicare patients, so all patients with the same type of insurance. And so, this is not a comparison of someone with Medicaid versus someone with Aetna. All have the same type of insurance. And there are areas in our country, lots of them in the Southeast, where the rate of amputation in people of color is significantly higher than others. And a big driver of that has to do with doctors just, again, making this decision. Maybe this patient is not going to be able to show up 3 or 4 times for follow-up care and all the complications that go with, a P.A.D. patient. So let me do this patient a favor and just finish it off right now and do the amputation and move on to the next problem. So one of the things that is so critical is this recognition and us spreading the word about unconscious bias in medical care. Doctors feel that we treat everyone the same, and we feel that we try to provide the best care to everyone. And fundamentally, those are true statements. But quite frankly, we all are filled with biases. I think back to walking down the wards in the hospital, and I've thought of times where, I'm in a room, it's a white family with grandpa and grandma in the room and brothers and sisters, and I see myself sitting down in a chair and taking out a piece of paper and a pen and drawing diagrams and really explaining the disease and the options. And then I could go 2 doors down, and it's a Black person who is by themselves and doesn't really understand things. And I basically say, hey, this is what we're doing, without a level of explanation. And again, and I'm a Black person, and I know that I've done things like that. It is just raising awareness, that making physicians know that even though their intentions are good, we often make decisions in regards to patients' care where our own biases creep in, and sometimes that leads to a recommendation for something that's suboptimal.
It's so interesting you say that. I want to jump in just because one of the catalysts for me really getting involved in the P.A.D. fight is one of my experiences at a Louisiana hospital where I was watching cases. This man was amazing with his hands. Some of the most complex cases, he was just finessing, right through the blockages, restoring blood flow is great. I said I wanted to interview him at the end of the day. He said, hold on, I'm going to take you to clinic with me and then we'll do the interview. in clinic, I remember the last case of the day, this African-American gentleman walked in. He was hobbling with a cane, and he looked actually about 85. I mean, he was only 50. He just really looked aged, and like he'd been through so much. And I was just heartbroken, but I looked up at the screen and I saw the imaging and I was like, oh, this should be easy. The doctor had more complex cases earlier today. This should be good news for this gentleman. But to my surprise, he said, I'm so sorry, sir. It's time. We've unblocked it a few times. And, you know, I think that we need to amputate. The man burst into tears. I couldn't legally say anything. He walked out the door and I asked the doctor, I don't understand why. You had more complex cases earlier. And this will, I can quote him because it rings in my ears. And he said, he's just a poor man, black man from the projects. He smokes, he drinks, he won't take care of himself, he won't walk. So why delay the inevitable? And in that moment, my entire life changed. And I felt like God was speaking to me. And I'm almost tearing up here. And I said, Doctor, you mark my words. You will not be amputating anymore on my watch. And I walked out and I started the Way to My Heart, which is now the global, P.A.D. Association. Wow, I've never, it's emotional during my thing. I'm going to turn it over to, I'm sorry, I promised Charles I wasn't going to cry.
I'm in tears. I'm in tears because everything that you mentioned, everything that you said, I experienced in my journey to where I am now. When this all started, I was here in Maryland. I'm just going to give you a small piece. When this all started, I was living here in Maryland, and these doctors, my primary care physician, the orthopedic surgeon, I visited them every day, and this started out as a small mosquito bite. It started out looking like a bump, a small mosquito bump. And every week or so, I would go to the doctor and say, it's changing. So then it went from looking like a mosquito bite to it looking like a flat undershirt with posts underneath, just flat. And then I got my first amputation because they waited until my toes were black. I mean, black to the point of no return black. That's when they amputated my toes, and they didn't tell me why, but they just said that they needed to be amputated at that point. So it's a lot of the things that you said in your story that resonates with me so deeply.
Dr. Browne, can we talk a little bit about the work that you're doing now with Janssen, the Save Legs Change Lives, especially the Empower van? I think that thing is really cool and it can do a lot of good. What can we expect from that program and the van in 2024, and how can we get involved?
Yeah, because
Yeah.
it's so important because, channeling, it sounds like not only your purpose and your passion, but also that of your wife and literally continuing that fight, for your father-in-law every single day. I'm sure he's right there, with you both in mind and spirit.
Yeah, so in 2020, we all know the world was kind of falling apart. COVID was ravaging the world, and it was interesting. In October of 2020, I saw a special on TV, and what it talked about was it talked about the fact that Blacks were dying from COVID at up to 3 times the rate of whites. And I was like, that hit me. I was like, that's weird. Why same virus? Why would there be a racial disparity in regards to um, um, COVID deaths in this country? And then in November of 2020, the then CEO of Johnson & Johnson, a gentleman named Alex Gorski, announced that J&J was going to be making $100 million commitment for something called Our Race to Health Equity. and an attempt to reduce health disparities, across the world. And that's when I started thinking about my father-in-law again. And I was like, wait a minute, he had peripheral artery disease, and his outcomes was likely worsened by the fact that he was a man of color. So I started to pay attention to this. That's when I actually first saw writings from Mary Yost, and I started to recognize that, wow, this is a big problem. And that gave me the impetus to join Johnson and Johnson. So I became part of the team at J&J in the summer of 2021. I came there and I met some really amazing people who also cared about health disparities. We formed a cardiovascular health equity task force, and then we picked as our North Star, how can we reduce the rate of P.A.D. related amputations in Black Americans? And we started this initiative called Save Legs, Change Lives that was announced at the American College of Cardiology meeting in 2022. And this initiative, Save Legs, Change Lives, has three pillars. So the first pillar has to do with research and a scientific approach to P.A.D. related disparities. So we're digging into data and showing that these disparities exist. We're going to physicians and talking to them with our heat map about, why people of color are having less revascularization procedures and more amputations. We're currently working on a publication because people say, well, the reason that Blacks do worse is because they show up with more severe disease, and ultimately, what can the doctor do? But we're actually going to publish a paper where we took data from the Society of Vascular Surgeons database, and we normalized it. We had people with the same severity of disease, and you'll see that Blacks, even starting at the same starting point that whites, they do worse. So there's a sort of research and scientific component to Save Legs, Change Lives. The second part of the second pillar has to do with us connecting and working with partners. So partners like Kim and her organization. We've partnered with the American College of Cardiology because we believe that concordant care, meaning people receiving care from people who look like them, increases the likelihood that they will be compliant with medical recommendations and improve their outcomes. So the American College of Cardiology has a program that we are supporting called Change the Field, and it's attempting to increase the number of female, Black, and Hispanic cardiologists in America so that there's more of us to care for these patients. We've worked with many other organizations and continue to do work with other organizations and our governmental affairs partners to try to push forward legislation that would allow for ABI screening for high-risk individuals. And then the third pillar of Save Legs, Change Lives has to be being in the community and raising awareness and detecting disease earlier. So we have faculty members. First of all, it was all Black faculty members. We have now expanded Save Legs, Change Lives to also focus on the Hispanic community because their numbers are also poor. And faculty members go into communities and at a fifth grade level, talk to individuals in those communities about what is peripheral artery disease. There's pictures of arteries and what plaque looks like. And we go through all the risk factors and testing and all the things that will empower these individuals that when they're in front of their doctors, they know the right questions to ask and they know how to advocate for themselves. And then the other piece of our empowering communities pillar of Save Legs, Change Lives is we have 2 mobile units that go out into the community and do what we call ankle brachial index testing, where you check the blood pressure in the arms and compare it to the blood pressure around the ankles. Those should be the same, but as you develop peripheral artery disease, the blood pressure around your ankle starts to fall. So this is a way to detect earlier someone who is developing peripheral artery disease. A test I wish that my father-in-law, someone had recommended that for him. I think it could have significantly changed the course of his medical journey. And we're, going through multiple communities with these mobile units and providing ABI testing for free, so that individuals can have their P.A.D. hopefully detected earlier, get on a walking program, get on appropriate medical therapy earlier, and hopefully reduce their risk of having a P.A.D. related amputation. I feel very fortunate to be at J&J, and leadership there supports these efforts. I have a tremendous team. My health equity director, Dr. Jillian Stevens, she's actually on this call, and my associate director, Chris Ewan, is actually here in San Francisco with me. And there are so many other people in the community. Carla Rideau, who's in Houston. So many people in at J&J have really gotten behind this effort. One thing I should point out is that one of the places we were in screening was Houston, Texas, where we showed up with our mobile units and we did this ABI testing on individuals in that community. And 41% of the individuals in Houston had an abnormal ankle brachial index test, which means that 40% of these patients very likely have reduced blood flow in their legs and aren't even aware of it. And these are the same people that will show up in an ER at 2 a.m. and with critical limb ischemia, and as Mary showed you, have a very high chance of having that leg amputated before they're discharged from the hospital. So we have a website. I encourage everyone to go to it and send it to other friends. www.savelegschangelives.com. Spread the word. P.A.D. has a PR problem. Enough people don't know about it. More people need to be aware of it. Individuals, patients, doctors, legislators. So the Save Legs, Change Lives initiative is all about raising awareness, early detection, changing legislation, scientific exploration to shine a light on this, and partnering with other organizations that care about this very, very important health disparity.
Thank you. Thank you. Douglas, you have a question?
Real quick. Yes, sir. Where are you finding the most resistance from? What side of the table? Where do you find the most resistance from today in making those changes that y'all working on?
So a couple of things. Number one, I'll give you a perfect example. We had that ABC News Live special, and there's a video of it out there, and a friend of mine sent it to some doctors who he knows. And what he told me was he got a lot of pushback from a couple vascular surgeons that he sent, where they felt, oh my gosh, this ABC special was all about race and playing the race card, and really and truly, let's be honest, Black people don't take care of themselves, and let's not blame the physicians for what's going on, whatever. So there is a certain amount of ignorance around people feel that it's all on the patient showing up late in the disease. And again, I am not saying that there's a responsibility of the patient to take care of themselves and to do the right thing in regards to their health, but so many are unaware on the patient side, but also physicians also have to take on some responsibility for this disparity. The other thing that I should point out is that from a hospital system, and my main job at J&J is to interface with health systems and improve their care of patients. But we have gone to health systems and chief medical officers and directors of vascular surgery, et cetera, and talked to them about these disparities. We've talked to them about why reducing the rate of amputation in their hospital is the right thing to do and why it's better patient care. But what we also recognized was one of the areas of resistance is the economics of P.A.D. care. And what I mean by that is an amputation, patient gets rolled into an operating room. It's a 40-minute operation. They're sutured up. They're done. The hospital gets paid a DRG, and they're on to the next case. Peripheral revascularization procedures can sometimes be very lengthy. Sometimes they can be 4, 5, 6 hours. That's a very long procedure for one DRG payment. So there is sort of a thought that, well, it might actually be economically better to have an amputation performed and just move on to the next patient. Now, we are in the middle of putting together a presentation in collaboration actually with Mary Yost that shines a light on the economics of this. And what I just said is absolutely wrong. It's actually, to a health system, much more expensive to do an amputation because of the complications associated with an amputation, infection of the wound, now back in the hospital needing treatment, higher risk of cardiovascular, poor outcome, ICU stay because of an amputation, patients falling, and beyond just the economics, we felt that we needed to create that narrative to talk to health systems and not only tell them from a medical standpoint, reducing your rate of amputations is the right thing to do. From an ethical standpoint, doing that is the right thing to do. But we also feel that we needed to arm ourselves with an economic story so that they understand that there's cost savings to the health systems also by reducing their rates of amputations.
And we wanted to jump over. Dr. Zola Ndandu had a quick comment as well. He wanted to chime in.
I really want to thank Dr. Browne for sharing your personal story. But, when you share your personal story, somebody might say, well, that's only a one-off story. But then you bring up the whole perspective of the data and everything that's associated with this, and the hard work that you're doing traveling around the country, trying to make this better. So it's a very, very big deal. So I want to share two things. Can you hear me okay still?
Yes.
Yes.
Okay, very good. So the one thing I want to share is a story about unconscious bias, and then I'll talk about something else regarding proper foot care. So I took care of a patient once who started a journey at another hospital. And while she was there, she lost her left leg, and she's depressed, everything you can imagine. This is a woman that was sophisticated, but that's her demise at that time. And while she was in a hospital, she developed an ulcer on the right foot. So she can foresee what the future will be like because she already lost the left leg and she's struggling with that. And she was taken to the angiogram suite. They attempted to open up the arteries to the right foot, but could not. So after the procedure, the team came and spoke with her, and the physician spoke with her. And they told her that we couldn't open up your arteries. So she looked at the main physician and asked the physician, said, Doctor, I just lost my left leg and I have a wound on the right. And you just told me that you could not open my arteries. So that means more than likely I'll lose my right leg too. And the doctor looked at her and says, strong possibility you will. And so the patient looked at him and asked, do you know anybody that can help to open my arteries so I don't lose my right leg, just like I lost the left? And the doctor looked at her in the face and says, no, good luck. So That's her story. That you're probably going to have to come back and get amputated, but good luck. So she goes home, depressed, crying the whole time, and goes to her podiatrist. And her podiatrist sees her and talks to her. She tells the story. And the podiatrist says, well, I know somebody that can potentially help. How about you go see him? So she comes and sees, not necessarily me, but our team. We sit down, look at everything. We say we can try to help. And she's really stoic and quiet, just looking at me. I explain what we're going to do. She's looking at me. And then she asked me, but Dr. Such and Such couldn't open it. How come you think you can? I said, well, I remember our conversation before we started all of this. You told me that you had been praying so hard for your arteries to be open. I cannot guarantee you that I can open your arteries, but I want you to keep on praying as you have been for yourself, but for me and my team, so we get to succeed. So we take her in, we open her up, we fix all her arteries, and everything goes well. So at the end of the case, I go to speak with her after she's awake and chatting with her. I explain everything that we did. I use the Doppler, pulses are loud. She says, doctor, does the other doctor that took care of me knows the work, knows who you are? I says, yes. Does he know the work that you do? I say, yes. So how come when I asked him, he told me he didn't know anybody and good luck? I said, I cannot answer that question. Now, going back to unconscious bias, this person is a good person. But at that moment, didn't realize that he offers suboptimal care to that patient. Not being able to treat the patient didn't mean that that patient care ended there. He or she could have gotten the phone and called somebody else. And so when you love somebody, that's my takeaway from this. When you love somebody, when you look at somebody as yours, as your equal, as your mother, as your uncle, as your father, you do what's best for them. Meaning you get on the phone, you call others, you seek what's best. But when you don't have that in you, we talk about empathy, sympathy, compassion, then these are the things that happen. Now, this woman, you can say, okay, she wasn't poor, she was educated, she had transportation, she had everything that she needed. But at that moment, what that extra help she needed was not given to her. So that's a good example of unconscious bias. That physician didn't realize at that moment that they let this patient down. We treated her and she's fine. She walks with a prosthetic. Her right leg was never compromised. And unfortunately, she lost her left leg. So that's one example.
Yes.
And I want to go to what Dr. Browne mentioned earlier regarding things that could have been told to his father-in-law. One of the things that I usually do as I see patients that come with P.A.D, everybody shoes and socks are off. And among the many things I've learned from my podiatry colleagues is I always ask them 3 or 4 questions regarding proper foot care. Among other, I'll ask, who's your podiatrist? Who takes care of you? I make sure they have one. Number 2, I always ask them, do you ever walk barefooted? And I'll ask them, who clips your toenails? And if they ever say, it's me, immediately I tell them, you're fired. You can't do that. Tell them they have to see a podiatrist to make sure that they have somebody who's professionally trained, who can take care of their feet. Just having a podiatrist decreases your rate of amputation. When it comes to proper foot care, I'll tell them, you might think because your house is paid off that you know your house that well. The reality is you don't. And nobody wakes up in the morning planning that today I'm going to walk and hit my baseboard, but it's going to happen. So if you have P.A.D, any injury can lead to CLI, gangrene, and then all the bad things happening. So it's really, really important for proper foot care. So I tell every patient to make sure that they never walk barefooted, always wear shoes, see a podiatrist, and then me as a cardiologist, then I make sure that we address all the cardiovascular risk factors. I go crazy when I have patients who smoke. I put every bit of effort to help them through that journey. It's not that you need to go home and quit smoking. I enroll them in smoking cessation programs so that way we have a good success of becoming smoke-free. and to remain in remission of tobacco exposure. So these are the things that we're doing, in a small scale, but hopefully, if there are 10,000 of us doing this kind of work, if we have 10,000 of the Dr. Browne around, of the Mary Yosts, hopefully we can make a difference. Thank you very much for your attention.
Absolutely. Thank you, Dr. Ndandu, for that. And thank you, Dr. Browne. For Dr. Browne, I have a final question for you. You and Dr. Ndandu have both touched on it. We've went over it a lot in our planning sessions that there's a lot of mistrust in the healthcare system, and it's been that way for many generations in our community. Was it like that for you in your household? And was it ever a factor in your decision to become a doctor? And do you still have these concerns today?
I absolutely still have these concerns, and that is why I'm a really big believer in concordant care. I really feel that, and this has been shown in the maternity literature quite clearly, right? That if a Black pregnant woman is cared for by someone that looks like her, infant mortality goes down. So I'm a big believer in sort of having people that look like each other taking care of each other, taking care of the patient. I think that goes a long way towards this barrier of mistrust. The second thing I also think is important, though, is education of patients, because we have many examples where patients just don't trust what is being recommended to them. My wife is actually a gastroenterologist, and she battles with patients not being as interested in a screening colonoscopy because they've said things from we don't we think that you might be leaving behind some kind of tracking device, and or we feel that this is experimentation. So there's also an element where patients need to also be educated that, yep, there are things that are historical that might make a person of color feel that they should not trust the healthcare system. But the vast majority of physicians, regardless of the color of their skin, have good intention. And a removal of this barrier in regards to mistrust really should be front and center in our minds, because it is an impediment to equitable care.
And I do have a very special guest as well that's here today. We have legendary Harlem Globetrotter Larry Shorty Coleman, who has been waiting to talk to you, Dr. Browne, and sharing his experience as well, because he can certainly share from experience that there is, a generational and cultural and historical, mistrust even in his family. Shorty, do you want to go ahead and jump in and say hello to Dr. Browne? And go ahead and share your experience as well.
Yes, good evening to everyone. And Dr. Browne, thank you very much for sharing. And thank you, Kim, for making this possible for us to share this during Black History Month or any other month. I am the legendary Harlem Globetrotter Larry Shorty Coleman, no better than anyone else. But with the experience I had to go through, seeing my mother through diabetic lose her leg, I said, there's no way in the world a guy like me that's running up and down the court, running my mouth 24/7, this is going to happen to me. But you never know what God has in store. But anyway, that did happen. And I suffered I believe it was in 2020. I had felt like I had a cramp. I felt like I had pain in my calf. Believe it or not, I was being stubborn. And I said, I'm not even going to go to a doctor. I'm just going to rub it, ice it, put heat on it. It got worse. and I went to emergency. Believe it or not, everything you guys are saying on this podcast, it came to light just listening to you. Unfortunately, I went to emergency, and first thing they did was go get an amputated doctor. I had no idea whether I was African American, white, yellow, or blue. He said, "Oh, sir, we're going to have to amputate that leg." And I looked at him like, if you think you taking my leg, and knowing I got a lot of more work to do, running, jumping, and walking. So I left the emergency on my own, and about another week or two, pain got very excruciating. So I went back. I had that doctor come in again, and he said, "Well, I'm going to have to admit you." He admitted me, then he came into the room 15 minutes later. Well, I think I'll have to schedule surgery in about 15 minutes. He don't know. I'm used to people getting called for 3 seconds being in the lane, but no way are we going to surgery without me speaking to at least 5 to 6 more doctors, which I did. However, they said that doctor shouldn't have told you that. Well, anyway, he did. But come to find out, other doctors say, "Well, we're going to try this, we're going to try that." I felt like I was an ingredient. They was just mixing things to me, and I'm not going to say I'm not educated enough to understand what they were saying, but I've never had this type of injury and never had anybody tell me about it. And fortunately, I had 8 operations, not 2, 8. Taking graft, putting the stents, doing this, doing that. All right, where do I go from now? COVID was going on at the time. I had no family members there to communicate with besides on the phone. One particular evening while I was in the hospital, I got the worst pain in the world in my left lower leg. And you talking about crying and boo-hooing. So I told the lady that I needed pain medicine. I was already on every pain medicine that you could name. And I said, I am used to taking Tylenol or aspirin. Even though we're saying this, I asked for the doctor to come in. I said, okay, just remove this leg. Well, he lowered the lower part of my leg. You talking about a gentleman that's been playing sports from 11 years old to 62. I lost my mind. I lost respect for whoever was in the room after the fact they had removed it. It was devastating to me, but something tapped me on the shoulder, which is always the good Lord, if for those of you that believe it. He said, I'm going to make you stronger than ever through this. He did. And however, today, I'm still going teaching kids how to be positive through sports and how to learn how to walk with the prosthetic once again. Since 2020 now, I'm having a very hard time. I'm not young anymore. And it's very difficult because the disease, P.A.D., has traveled to my other leg. Make a long story short, I'm not going to give up, and I hope I can encourage others to be enthusiastic as I am. And most of all, don't say you can't do it. Just keep trying to do it. Like me and Kim say with weight in my heart, one step away from being the next step. So now passing on to my family members. I have a nephew that lost 2 lower legs at a young age. My oldest brother lost half his foot. My uncle lost a leg at 70, 80. And we must spread this. And I'm glad you guys are having this type of podcast. And I thank you very much for having me. And God bless.
But Larry, thank you so much for sharing. But you were mentioning, and we've talked about your nephew and some of the other family members, and you reached out to us to help you save your other leg. Why is it that your other family members are so resistant to help and they continue to say yes to amputation? Why are they letting this happen?
I think they're letting it happen because of the fact they're not listening to what I'm telling them, because I'm not a doctor, but I am their relative. So I don't understand why they won't let me have them call you, who advised me to a great doctor, as well as the great doctors you have on the panel, Dr. Red. Now I'm with Dr. Dre Diploma, who's another great guy who helped saving my leg. And I'm doing the best part, going to therapy and doing on my own and keep the blood flowing as best as possible. But again, with my relatives, it's a thing called being stubborn. And that's something majority of us as African Americans do when it comes to doctors and going to the hospital.
Yes. Why is that? What is your understanding? What goes on in the conversations from generation to generation that has led to this mindset?
I think that it just basically comes from being stubborn and seeing older people growing up that you take for granted they're old. That's why it happened to them. And you get fixated with that in your mind. And that's not a good thing to do. But I'm going to continue to tell them, you don't have to have your leg amputated. You don't have to have your piggies gone. You can do something different. It's 2024. Wake up and smell the coffee.
No, that's very important. Kim, can I add one or two things here?
Yes.
It goes back to a couple of things Dr. Browne mentioned. When you have physicians who also, or a patient look like the physician or vice versa, I think it goes a long way. So I can use one example here. As I mentioned earlier, I am originally from the Democratic Republic of Congo. Born in the U.S., grew up there, so my formative years were spent there. And Congo, for those of you that don't know, Central Africa, it's a former Belgian colony, population of about 100 million. That's how many people are there. There's not a single angiogram suite. So if you have critical limb ischemia, you just lose your leg. So because of all of that, currently in the Congo, when somebody has critical limb ischemia, has gangrene, people really think of it as an illness that somebody put on you. So here in America, we say somebody put voodoo on you, juju, jazz, whatever you want to call it. So here I am practicing in the US, and this is what I do all day long. And so when I get international consults or when I travel to Congo, it's a lot of work having to explain to people that what you have, it's not because somebody has done something that, intentionally against you, is because you have poor circulation that we can work on. But to be able to do that and to break those barriers, it takes time, it takes energy, and going back to what I mentioned earlier, it takes empathy, sympathy, compassion, and also a fundamental understanding of who you're dealing with. The fact that I grew up there and I understand the cultural nuances, when I have these discussions, I know how to navigate through these waters to help the folks understand. And so some of the things that happen here is you have patients who come in contact with physicians, and even before the physician walks in, he or she, there's already a mistrust. And so those barriers have to be broken. And that's effort on both sides. So really, it will take everybody to put effort to break down these barriers, to increase the pipeline of physicians that can respond to these needs, so that we get to address these issues. Because if we have technology available, and the only reason why it's not making it to save these limbs is mistrust, well, we need to work on that. If we didn't have the technology, that's a different story, but we have it. So that's where we have to put our effort, and hopefully we get to do that. Thank you.
And I also like to jump in and say, if more doctors were like you all on our podcast right now, and our family that's been sharing with way to my heart, is such a mega dollar that a amputated doctor makes, because I only go by that from when I get my summary from my insurance. I think that plays a big part. I don't want to step on no one's toes or make them feel bad, but it's a big business.
It is a big business. It's a huge business, and it's getting even more bigger. Let me tell you why it's getting larger. We, as peripheral artery disease patients, warriors, we were put on the side burner because there was nothing that they could gain from us at that particular time. Now we are considered the hot commodity in healthcare, in trying to solve the situation. Therefore, the great doctors that have been out there fighting this fight with us, along with us, and for us, are being pushed out by greed. How do you go about giving your patient, you want your patients to have the reassurance that you're going to help them through, regardless of what they're going through. But if you feel as though you're just a number, you're just a file, you can't even get an eye-to-eye contact conversation going. What's the point of me trying to be there, getting resolve from you when you're not, I'm seeing you're not going to help me. You're just going to take another piece of me. And when every time you take a piece of me, I grieve that piece that has been taken. I grieve because that piece that I was born into this world with is gone. And now I got more medications I have to take. I got more medical issues I have to deal with. And you can go on your yacht and chill. You know what I'm saying? That's stressful.
Very much so.
For you to put, for doctors to put us in such a shell, in such a cave, to whereas they only want to pull us out when we're the it thing. Cancer has been the it thing forever. The color pink, yes. The it thing forever. Why can't we have that same it thing? Because just because it's Black History Month and we're talking about this, Black History Month, for us, this is an everyday occurrence. This is a wake up, go to sleep. This is a how am I walking today? Am I walking straight or not? Am I moving differently to where people can notice that I don't have part of my body that I was born into? There's a lot of trust issues. But when I first meet my doctors, I trust that they're going to give me the information that I need in order to educate myself better about my condition. Therefore, going to another doctor, I'll be able to explain to them in layman's terms what I just learned from the doctor I had before. We don't get that. We get, you might have poor circulation, but look, they're purple now. They're Black now. We got to cut it off. We're still going to be a liability because now you've cut it off. I still got to come and see you. You still got to help me heal. I still got to have all these different medications. It's a lot that we go through that after you cut it off, it's over. It's done. How do you have patients deal with that?
And Thea, your daughter is actually jumping in the chat. I'm not sure if she wants to unmute really quickly, but she's talking about the fact that fear and mistrust are related. And I'm curious, with your experiences, how that's also leading to the next generation of fear and mistrust. And, her ultimately maybe not getting diagnosed soon enough, only at the point where amputation becomes the only option. That's scary. That's really scary to think about, that it just, this domino effect keeps going and going and going.
But that's my, Kim, is what I'm trying to say is they had plenty of time. We had time. It was a mosquito bite. You understand? We had time. I was going to all my visits. They was doing everything but what they were supposed to do. I found out about Doppler by going to Michigan and then coming back and saying, oh, you got to start doing this because that's what they did to me in Michigan. But whenever I come back here, the first and only thing they want to talk about is amputation. They don't understand. I'm willing to have this fight. I'm willing to go through all of these things in order to have a quality of life that I deserve.
Right. And when you stand up to speak your mind, what happens? You get silenced.
They silenced me. I went on YouTube telling my story, showing my video, letting them know what I was going through, what I was experiencing. And the first thing they want to call me is an angry Black woman. No, I'm not an angry Black woman. I'm pissed off because I'm trying to explain to you what's going on with me. I need you to understand that I have learned to listen to my body, and I need you to listen to me. But yes, you're the doctor, but we can teach each other. It's not just what you say goes, because I know a couple of things now that I didn't know at the beginning of this journey. And I'm still willing to fight every fight that I need to fight. But I need people around me, my team, to be ready to fight with me.
Thank you so much. And we have Felicia that might want to jump.
Yes. Thank you, everyone. I think all the doctors and everyone that's come on. It's so helpful. It's disheartening. My son passed away last year, and he had he had a small cut between his big toe and his other one. And, we put some stuff on it and put a Band-Aid on it. And as we, you go to the doctor, they clipped his toenails, and then it had gotten just a little pus on it, I guess. And the doctor said, no problem. He just said, what do you call that stuff? Betadine. And then it got worse, and we called the doctor. We need to come in on an emergency. And he said betadine. No, we betadine that until he lost his toes. And it was only like 2 toes, but the doctor wanted to cut off all his toes because he was trying to save them all. And then the situation went to it was left foot, then the right foot. And it was every time we were asking, why is this going on? We never, ever got a test for P.A.D until we met Dr. Ansari. And Dr. Ansari was able to put stents in his legs. He was on dialysis for 12 years. And we never got a conversation from them. Been going to the foot doctor. He's been cutting his toenails. We don't cut them. I am so angry because I lost my son because of all of this unnecessary. Doctors don't explain. Every time they say it wasn't all diabetes. It wasn't all diabetes. It was something that could have been taken care of, but they chose to tell us. By the time I got researched everything, I think he had already lost a few toes. But Dr. Ansari saved his legs. But then he had a heart issue that from dialysis that we didn't know about. The heart doctor didn't see it. He took the test. Gary had a heart attack. They say, well, he's fine. I'm like, okay. So we meet Dr. Ansari. Dr. Ansari took some other tests. And then he sent us to a different doctor. And that doctor gave us the news of our life, the surgery that had to be done. It was just unending. Then after the heart surgery,
after the heart surgery, that was one of the hardest moments because I lost touch with Felicia and I kept thinking something's wrong. And I kept messaging and she finally called me and she said, I'm so sorry, I've been out of touch. I have to make the hardest decision of my life.
Yeah, and I kept telling you, I had to take him off life support. And then Gary woke up and it's like, wait a minute, Gary says he want to do everything he can to
But before
live.
they did that, they said they wanted to take you off.
Yeah.
And I said, not on my watch. They're not pulling the plug. And I said, you need to call Dr. Ansari now. And Dr. Ansari ended up calling that hospital and said, have you even done standard protocol and even tested to see if he has any sort of brain waves? And he did. And within 24 hours, right?
They moved him.
Woke up.
Yeah. Wide awake.
And they were going to take him off life support.
Right. I mean, the head of the department, the head of the hospital coming down and telling me I'm doing the worst thing ever to not take him off. I'm ruining his life. I'm making him suffer. And I mean, I cried for weeks and I refused to let them do it. And they pressured me and pressured me from the nurse to the doctor, every single doctor. And I thought it was cruel. It was just cruel. We ended up going to a convalescent, I think, and he had a huge bed sore that was astronomical. But I like to say that, Gary woke up and he woke up really well and he was lively and talking for about 3 months. And we don't know what happened at all. But I can tell you that there was not enough nurses to keep him clean. There wasn't enough doctor care through his whole entire time.
Whoops, we are having a little bit of issue with Charles.
Even going back to when he was first diagnosed, he was about 5 years old when they said he could become a diabetic, And it was just not the care. When it was like back in the time when your parents had medical insurance, but if your kid didn't go to college, then they became off. But Gary was diabetic. But so we had to go to this thing, I forget the name of it, and that's how he would get his medicine, and to a point where they wouldn't give him his medicine. And it was just a fight to get the medicine. So Gary was 18 years old. He did, like, if I'm going to die, I might as well live my life. And so we went through a lot of changes medically, and I can tell you it's just never got explained, never got tested the way it needed to be, not even going through dialysis, not even fighting the doctor. And the more we said that something was wrong, even for my own self, I've had to fight for pain issues. And so they come up with this thing, fibromyalgia. But, so it was hard. It was very hard. And I'm here to fight for people at any, where I hear it, to tell them about it so that they don't have to. I didn't know he didn't have to get his toes amputated. I didn't know he could have took tests to find out whether his artery was clogged. I didn't know he didn't even get a stent put in to open up those. It could have happened way when he got the little cut. They could have sent him to get his legs checked. They didn't.
Dr. Browne, I see you shaking your head. You want to jump in here? It's really disconcerting, isn't it?
Well, two things. First of all, I have a question for Larry. Larry, when you presented with your the pain in your legs and went to the ER the first time, was that the first time you had pain, or did you have chronic discomfort in your leg that was coming on whenever you walked?
It was the first time I felt that pain, and it continued. That was the first time I've ever experienced it, even through playing sport.
Yeah, the point I want, 2 points I want to make. Well, first of all, Kim, thank you so much for including me in this very, very important discussion. But the first point I want to make is that if you go down the street and you grab 100 people and you say to all 100, have you ever heard about something called a heart attack? I guarantee you 98 of them will say, of course I have. If I pick another 100 people and I say, have you ever heard of something called a stroke? 98 or 99 of them will be like, of course, I know exactly what a stroke is. If you then find another 100 people and say, have you ever heard of peripheral artery disease? I'd be surprised if 40 of them say, yep, I know what that is. I recognize that name. So one of the biggest challenge we have is, quite frankly, raising awareness, and folks on this call, really and truly spread the word any way you can, because we definitely have an awareness problem. The second thing to Larry's presentation is, sounds like he presented with clinical limb ischemia. And a high percentage, almost 40% of patients with peripheral artery disease, obstructive peripheral artery disease, actually don't have symptoms. Either they don't have symptoms or they have atypical symptoms.
Right.
They have things like, wow, I'm losing hair on my legs, or my legs feel cold at night, or they feel heavy, or I'm feeling numbness. It must be a nerve issue from my diabetes, and lots of atypical symptoms or lack of symptoms in a high percentage of patients. That creates a medical problem because again, lack of symptoms leads to lack of diagnosis, which is why being examined by your doctor and having your feet examined is so important. That allows for earlier detection of peripheral artery disease. And the second thing is, be on the lookout for efforts by different groups and organizations to allow for screening in high-risk individuals for peripheral artery disease. The American Heart Association and the American College of Cardiology a few years ago published a statement where they felt that in high-risk individuals, we should be screening just like we screen for breast cancer in women over 40, or we screen for colon cancer in people over the age of 45. We don't have a mechanism to screen for peripheral artery disease in higher risk individuals. So when you hear of efforts to get that done, support it. Talk to your legislatures in your community. That is also a very big missing piece to this dilemma that we're experiencing. I feel very moved by lots of the discussions today, and I would like to thank you, Kim, for giving a damn, for caring, for trying to mobilize people to make a difference in the lives of individuals. Thank you so much.
Thank you, Dr. Browne.